Dr. Hassan Kiki, radiology professor in radiology department, Cairo University. Dr. Rasha Rifai, Prof of hepatology, gastroenterology, internal medicine department head in Helwan University. Dr. Wasim Gindi, professor of radiology and head of radiology department in military hospital. And Dr. Salim Wadi, consultant of radiology in National Liver Institute. We will start with the first speaker, Dr. Khaled Sayes.
Okay. You guys hear me?
Yes, we can hear you, Dr. Khaled. تمام حضرتك جاهز نبتدي؟
Yes, yes.
I would like to welcome Prof. Dr. Khaled Sayes. Dr. Khaled, Professor of Radiology, Abdominal Imaging Division in University of Texas. تفضل دكتور خالد.
Okay, thank you very much for the kind invite, and it's my pleasure to be with you. I'm going to talk about diagnostic algorithmic approach and pitfalls of enhancing observation in cirrhotic liver. So I'd like to thank you for inviting me to this lecture, especially my classmate and my friend, Dr. Muhammad Fauzi. Give me 1 second. Let me adjust the camera here. Okay. So I have nothing to disclose. Before we started, those are the objectives. Why enhancing observation, particularly in cirrhotic? And I'm going to go overview of hepatocarcinogenesis and LIRADS version 2018 algorithm and major features, as well as differential diagnostic considerations and pitfalls. Why cirrhosis? Because over 80% of hepatocellular carcinomas occur in cirrhotic liver. This is the second common cause of cancer-related mortalities worldwide, and we know these are the common causes of cirrhosis, and that's why it's also endemic, or it's very common in my beloved homeland, Egypt, as well. And that's why we have to really pay a lot of attention to this. One of the most important pitfalls result from the disorganized reports. In particular, the free-form report here, when we talk about something like that, what are you getting out of this? So the radiologist here, and I see that this is very common, actually. This is the more common scenario is that, radiologist doesn't give definitive report, structured report to be useful for the hepatologist or the hepatobiliary surgeon. And this is, for example, here, the radiologist saying that there is cirrhosis, portal hypertension, hypervascular mass in the right hepatic loop, a possibility of HCC is not excluded. What is our non-radiologist colleague is going to benefit from this? Nothing, actually, because you're not telling them what you're thinking about. Here are important questions to consider when you are reporting an observation. Did you report arterial phase hyperenhancement in this observation? Is there portal venous or delayed washout? Is there a capsule? How much did the index lesion grow since the prior? What's the diagnosis? What's the radiologist's confidence level in the diagnosis? So the same patient with different reporting system. This is structured report. And we developed this in the LIRADS group. And here you're telling the non-radiologist colleague definitively what you're thinking about. You're thinking about cirrhosis, portal hypertension, and then you're describing clearly these major features in the report. Here I'm going to show the report, but this is your impression. You're telling them that you're dealing with definite HCC observation, and you're localizing the segment, and you're telling them exactly what you feel. So this is the structured report and how it looks like, and including even the clinical indication. This is very important, and we're going to go over this, including the technique. It's very also important, and prior study. And then you are mentioning here all major features after you indicate the presence of focal observation and localize it and measure it and the size here is one of the major features as well. So you are mentioning all of this, and in addition to this, you are mentioning also ancillary features that can help you in the diagnosis. This has an impact on the diagnosis or the diagnostic quality of your report for hepatocellular carcinoma, and this was found. It was found that the use of structured LIRADS template resulted in more comprehensive and consistent reporting of major hepatocellular carcinoma features and LIRADS category compared with free text reporting. And I showed you an example of this. And this is a different paper also published, which indicated that non-standardized reporting, non-standardized terminology results in inaccurate communication of the risk of HSC by radiologists and inaccurate estimation of the risk by hepatologists as well. So it's, as I said, it's very important to organize yourself, structure your report, because structured reporting improve communication, patient care, education, research, consistent terminology and text format, improve communication, reduce ambiguity in your radiology report. You know exactly what you're talking about, and you know the points of interest to you and to the clinician as well. So structured report compared to the free text report is more complete, clearer, more actionable, higher quality, better at guiding patient management, which will lead at the end to better care, which is our ultimate goal. We did a survey to clinicians and surgeons, asking them exactly what they prefer, and most participants prefer the use of LIRADS. This is the standardization system for liver observations in cirrhotic liver, and actually most of them prefer the use of LIRADS in reporting CT and MRI examination. And when considered inclusion of management recommendation, radiologists should consult with their referring physicians. So they don't prefer that we come up with the management itself. So we discuss it with them and the liver tumor boards, and we come up with a conclusive management. So it's very important to know that cirrhotic liver nodules like has multi-step hepatocarcinogenesis, and the majority of HSC are believed to arise in a stepwise pattern. That's why the survey, the screening is very important, and that's why the follow-up and observation of these nodules on follow-up imaging is very important. So the hepatocarcinogenesis started by what? Started by regenerative nodules that go with to low-grade dysplastic nodule, which is benign, and then high-grade dysplastic nodule, which is pre-malignant, and the small HSC, which is malignant and overt HSCC. Okay, so there are several examples for this, but again, what really helps us is LIRADS, which would tell you exactly how to categorize the observation that you see on cirrhotic liver. So LIRADS version 2018, and this was a huge milestone, which is being included in American Association of Study of Liver Disease practice guidelines, which paved the way for more widespread acceptance and implementation of LIRADS. And this was the diagnostic table of LIRADS, right, which includes hyper enhancement, as we see here, which include the size, which include the non-peripheral washout, enhancing capsule and threshold growth. This is the box, believe it or not, for them to accept LIRADS. This was the box that was implemented, and this box means that the washout has a precious value. Also, threshold growth has a very precious, very important value in inclusion, because it can upgrade the observation to LR5. If they are not present and non-enhancing or enhancing capsule is only present, then it will be LR4 here. That's in the enhancing or hyper enhancing observations measuring between 10 to 19 millimeter. So a case here is a 36-year-old woman with chronic Budd-Chiari syndrome. You see the hyper enhancing observation here. Would you start using LIRADS? No, you don't start using LIRADS, although there is a cirrhosis, because it's very important to remember the target population. And this target population is selected carefully to include the patients at high risk of hepatocellular carcinoma. Those are namely patients with cirrhosis and chronic hepatitis B without cirrhosis. So if you have chronic hepatitis B without cirrhosis, you can apply LIRADS because HSC can develop on top of hepatitis B without the development or before the development of LIRADS. And also if you have current or prior history of HSC. But you don't apply it in these conditions, including the Budd-Chiari syndrome, which I mentioned here. So due to vascular disorders, you have cirrhosis, you don't apply LIRADS because the FNH-like nodules and the regenerative nodules are a lot more common than hepatocellular carcinoma in this subset of patients. You need to also to apply LIRADS only when you have multiphasic CT or MRI, right? You don't apply it in a single venous phase standard protocol standard protocol abdominal CT or MRI. And you don't assign LIRADS when there is path-proven malignancies, when there is also path-proven benign entities. This is our step-by-step categorization here based on LIRADS. And I'm going to do it step by step. So this is, for example, first of all, you start by saying, okay, is this categorizable or non-categorizable? After, really limiting it to the target population, then you move on this can be categorized or cannot be categorized. When you have an imaging examination like that, then this is not diagnostic. Then you would not categorize the observation here. You would say this is LRNC, which is non-categorizable. What about whenever you see a tumor invading in a vein like this? This is an infiltrative mass with a tumor thrombus within the left portal vein. What do you do about this? This is what's called LR, tumor in vein. We used to say LR5V in the previous version in 2014, but tumor in vein is more reflective of the tumor because this tumor could be either HSCC or could be cholangiocarcinoma, because cholangiocarcinoma can arise on top of cirrhotic liver and can also invade the vein. But if it's definitely benign like this is like flash filling hemangioma, as we see retention of contrast following the blood pool and retention of contrast in the delayed phase, high signal intensity on T2, this would be flash filling hemangioma, which will be categorized as LR1. This is true for anything that you think or you're sure it's benign. It's definitely benign, such as cyst or hemangioma. You're moving to LR2, which is probably benign. Something like that can actually be freaking, which is because it's arterial hyperenhancing. But if you're sure that this is AB shunt, when you see it as wedge shape, hyperenhancing in the arterial phase, and then become iso-intense or iso-dense in the delayed phase, then this is probably benign. This is AB shunt, which is safe to say this is probably benign, and you don't want to do anything else about it. But you have this entity when you see a REM-like enhancement. This is not a common pattern in HSC. It can be seen in atypical forms of HSC, but here it's very wise to say that this is LRM, which is probably or definitely malignant, but not HSCC specific. Most likely what they do in these cases is they do biopsy of these cases, which will help you, definitely diagnose this mass, okay? So LRM is malignant or probably or definitely malignant, but not HSCC specific. So otherwise, then you do what? Then you use the CT or MRI diagnostic table like before. And those are very important to remember the major features. Those are the major features, which is non-REM arterial phase hyperenhancement, non-peripheral washout, enhancing capsule size, and the threshold growth. And threshold growth definition has changed in 2018. And this is the non-REM arterial phase hyperenhancement. Guys, this is very important to define clearly. It's called non-REM because we mentioned the REM was what? Was LRM. But when you have it as non-REM arterial phase hyperenhancement, you define it as unequivocally greater in whole or apart than liver. Not most pronounced in the periphery of the observation, because if it's most pronounced at the periphery of the observation, it will be REM arterial phase hyperenhancement. It may not be just diffuse or homogeneous. It could be some little heterogeneous or diffuse and heterogeneous scattered nodule in a nodule or mosaic. This is really required to upgrade. So if you don't have LR, if you don't have arterial phase hyperenhancement, as a major feature, non-REM arterial phase hyperenhancement, you cannot upgrade the observation to LR5. The second major feature is non-peripheral washout. And again, the definition is very important. It's reduction in enhancement from earlier to later phase, not most pronounced at the periphery of the observation. Exactly like what we see here. You need to see it in what? In portovenous phase or delayed phase, right? Or both of them, in order to define it. The third major feature is enhancing capsule. And this is smooth, uniform, sharp border, like what exactly we see it here around most or all of an observation, unequivocally greater or more conspicuous than fibrotic tissue around the background nodule. Exactly like this. This is really crisp. This is well circumscribed. You are like drawing it with a pencil, and it's visible as enhancing REM in portovenous phase, delayed phase, and transitional phase as well. You can read our article about the periphery in radiographics about this. The size is the largest outer edge to outer edge dimension of an observation, and 10 millimeter is the least size required for LR5 categorization. So if you have 1 centimeter and above, then you can categorize it as LR5, provided that you have other features to support this. But you cannot upgrade. So this is lesson number 2. You cannot upgrade the category to LR5 without having arterial phase hyperenhancement, number 1, and a size of at least 1 centimeter. The very important also rule is you don't use arterial phase and diffusion weighted image if the observation is visible on other phases. Because what? Because this is like blurry images that tend to hyperestimate the size. This is rule of thumb. If you have anything that is more circumscribed in the venous phase or the delayed phase, then you use it. And you include the capsule in the measurement, exactly like what I'm showing here. And the last major feature is the threshold growth. And the definition here is more than 50% in 6 months. This is an example for more than 50% growth in 6 months, which could be used as a major feature for categorization. Again, I'm going to show you this is non-REM arterial phase hyperenhancement, like exactly what we see here in the arterial phase. And this is REM hyperenhancement that we see it here in the arterial phase as well. REM hyperenhancement indicate what? Indicate LRM, but non-REM arterial phase hyperenhancement, then you do it in the diagnostic table and you can categorize it accordingly. So this is very important. So if we want to apply it, this is a very bread and butter case. This is very simple, straightforward case where you see major feature. You see what? Arterial phase hyperenhancement, right? You see enhancing capsule in the portovenous and delayed phase, and you measure it as 18 millimeter, as we can show here in this mass. So this is what? This is, you put it here as 18 millimeter. This is non-REM arterial phase hyperenhancement. You go here in this column, and this will be LR5, which is definitely hepatocellular carcinoma, right? And then what else we can, so the teaching point here is LR5 here indicates almost 100% certainty that the HCC is HCC here in this. Biopsy is not needed, right? So biopsy is not needed when you think it's LR5. What about this one? This is a mass that measures 9 millimeters. So this is, you know, less than one, this is then 10 millimeter. I know that we're Egyptian, we can stretch it to make it 1 centimeter in order to categorize it as LR5 if we think it's LR5. But let's follow the book here. This is 9 millimeter, or the question here, or the key point here is that you cannot upgrade this category to LR5. I mean, if we play this table, then this will be what? This will be, so we have arterial phase hyperenhancement, we have enhancing capsule and the washout, but if you apply it because it's less than 10 millimeter, it will be LR4 category in this case, right? What about the next case here? I'm just showing you how we do it, and you guys can practice it the way you like. And this is another case, you barely see the observation here. I don't think it's arterial phase hyperenhancement. So there is, it will go in these two columns here, which is no arterial phase hyperenhancement, and you measure it as, and then it has washout, and so there is washout in this observation, and there is no capsule. So you do it here, you put it here, it's 17 millimeter, less than 2 centimeter here, which will be LR3, right? Because it has only one major feature in this case. Okay, so these are a few cases to just to practice, and then you apply the ancillary features. I'm not going to be able to go in depth in all of them, but the point of it is you apply and you categorize it, you upgrade it for one category, or you downgrade it for one category. If it's ancillary features for malignancy, then you upgrade for one category, but you don't upgrade to LR5 as we see. Why? Because we aim to keep the very high sensitivity and the specificity of LR5. We want to say when it's LR5, it's definite HCC. That's why you don't use the ancillary features to upgrade to LR5. You can use it to downgrade because, again, you aim to keep the very high sensitivity and the specificity in these cases. You don't upgrade for more than one category, and you can't downgrade for by more than one category. So just one category, you can't use more than one major feature. You can use major feature of malignancy and benignity to cancel each other, but you can't use to upgrade for more than one category. Okay, this is an example. Those are the ancillary features favoring malignancy. Those are the ancillary features favoring HCC in particular, and those ancillary features favoring benignity. Those are general terms, guys. You can use it. You will not go wrong with those, right? If it's, for example, presence of fat within a mass in a cirrhotic liver, you use it for ancillary feature for HCC in particular because HCC can contain fat. Okay, nodule in a nodule is actually, this is a very early actually stage of HCC. Blood products in a mass, fat sparing in a mass, or iron sparing in a mass means that this mass has a different nature than the surrounding normal liver, right, or normal hepatocytes, because these cells, the cells of this tumor has been spared of this infiltration. And also ancillary features favoring benignity, stability, size reduction over size, barreling the blood pool. If you think that something is barreling the blood pool, then you think of hemangioma, right? Undistorted vessels, iron in a mass is more than the liver, market T2 hypointensity, right? And market T2 hyperintensity, actually, not hypointensity, hyperintensity, because you see that with hemangiomas and you see that with cysts, right? And we say an ancillary feature, something that's favoring, right? Not for sure. And the hepatobiliary isointensity, because hepatobiliary actually hypointensity is a very strong ancillary feature favoring malignancy. And that's how you apply it. You apply it to downgrade, as I said, but then last step, apply the tie-breaking rule. The tie-breaking rule meaning that you go for the lower certainty. So if you're not certain that this is LR5 or LR4, you downgrade it to LR4, right? And if you're not certain that is LR3 or LR2 or LR3, then you upgrade it to LR3. That's the lower certainty. Lower certainty of benignity, you go like this. Lower certainty of malignancy, you downgrade it, right? So you upgrade it if you think it's benign, right? If you are unsure or uncertain, and you downgrade it if it's malignant. Again, keeping the high sensitivity and the specificity and being conservative at managing these observations. This is how we use ancillary features. This is an example where we have an observation here in this patient, and this would be categorized as LR3. I think that's the same case that we categorize as LR3. But you have here fat within a mass indicated by the protein density fat fraction, and you upgraded with one category to be LR4 rather than LR3. Okay. This is another very important ancillary feature. In a matter of fact, this is actually definite HCC. This is nodule in a nodule. Why I'm saying it's definite HCC? Because when you measure it, you measure the whole observation, not just the central nodule here. The central nodule is demonstrating arterial phase hyperenhancement if you focus, if it projects well in your screen, but also it shows very well here the central nodule as hyperintense 22 arterial phase enhancement, and you measure the whole observation, it measures more than 1 centimeter, then this is LR5. But if it's LR3 with the presence of nodule in a nodule, you can upgrade it to LR4 because, as I said, it's an ancillary feature for HCC in particular. So you wrap up this and this table, and then you go to cases here. This is case number 1, and as I said, this is improper patient, inappropriate patient population. So you are aiming to use this in the proper patient population that I showed you, and it's actually illustrated in the manual. And I showed already this slide. It's very important for you to remember what observations you're dealing with. And I showed you this stepwise fashion, starting by regenerative nodule to dysplastic nodule to HCC on top of dysplastic nodule to early HCC, then to overt HCC. And this is the observation. And I already showed you how you categorize it as LRNC, LRTIV, LR1, LR2, LRM. But then with LRM, this is something that has been categorized as LRM, thinking that it's cholangiocarcinoma. It shows delayed enhancement or delayed retention of enhancement and volume loss, capsular retraction in this region. But this is actually a very common pitfall. I see it all the time. Radiologists should be familiar with this appearance. That's what's called confluent hepatic fibrosis. Guys, if you see this, then this is definitely benign because it's not LRM, because this is typical for confluent hepatic fibrosis. And as I said, it's characterized by fibrosis, which retract the capsule, which lead to volume loss, which is characteristically located in the anterior segment of the right hepatic loop or the medial segment of left hepatic loop, or both of them, like what we see here, and has some crowding of vessels. As I said, it has capsular retraction, and it's usually hypoenhancing. It could be hyperenhancing in a very small portion of these patients, and it's characterized by progressive enhancement in delayed phase. This is another observation that could be misinterpreted as LRM. You see REM enhancement here, very faint though, but you see it. But when you look at the previous examination, it's typical for hemangioma. Hemangioma could actually change its morphology in the liver because of the surrounding liver fibrosis that eats up the mass, shrink the mass, lead to this appearance of, REM enhancing observation. It could lose this peripheral discontinuous bubbling enhancement and become continuous, become sclerosed, like what we see here. And the tip here, or the key here, is reviewing the previous examination. Hemangioma is not as common as it is in non-cirrhotic liver, because, as I said again, the surrounding liver parenchyma doesn't welcome the benign pathologies such as hemangiomas and cysts. It's like in our, general street language terms, it eats up, the fibrosis eats up these benign lesions. So as we said previously, you go to the major features, right? After LRM, and I showed you some pitfalls of LRM, and I showed you some examples of how you measure the size, how the size is very important, and you measure it outer edge size of 1 centimeter or more is required to categorize the mass as LR5. What about this, guys? I'm giving you this. This is 15 millimeter. How do you do with this one? This is actually a case I'm trying to trick you with, but it's a real case that the radiologist has measured this in the arterial phase as 15 millimeter, but when he measured, or she measures it in the portal venous phase, it become much less in size. It become 8 millimeter. And here, when you categorize it as, when you measure it as LR, when you measure it as 15 millimeter, you categorize it as LR5, right? Based on this, which is you have the washout, you have the enhancing arterial phase hyper enhancement, and this is measuring 15 millimeters, so it will fit here. And because this patient has washout, then it will be LR5. But if you accurately measure it, this will be categorized as LR4, not actually LR5, based on this table here, because it will be less than 10 millimeter. That's why accurate measurement matters. You don't measure in the diffusion weighted imaging, you don't measure it in the arterial phase, because those overestimate the size of the observation. And then, as I said, don't use the arterial phase or DWI. Then you move to arterial phase hyper enhancement. Guys, this slide is very beautiful. Even if you don't use it for your knowledge. When we see something like this, this was actually interpreted as hepatocellular carcinoma. But I'll tell you why it's not correct, because that's how you see it in the pre-contrast. And the mass is enhancing, but it's enhancing similar to the liver, to the surrounding liver. So it's not arterial phase hyper enhancing, it's iso enhancing. There has to be unequivocal greater enhancement than the surrounding liver. Like what we see here, this is not unequivocal greater than the surrounding liver. So this is not arterial phase hyper enhancement. And here also using the subtraction indicated that it's enhancing similar to the surrounding liver. And this is not HSCC. It was biopsied and found to be macro-regenerative nodule. It's example of regenerative nodule, but really unusually big, like what we see in this case. So the question here, or very important here to remember the definition of the arterial phase hyperenhancement, that is enhancement to arterial phase that is unequivocally greater on a whole or a part than liver, not most pronounced in the periphery of the observation. What about this? Based on what? Based on my personal own teaching to you guys, I said you cannot upgrade the category here to LR5, right? Because it's not arterial phase hyperenhancement. But is this the correct phase? No, it's not the correct phase, because this is early arterial phase. And here when you do the proper late arterial phase, when what? When you start seeing enhancement in the portal vein. Then this is you see how this changed, completely changed your category or completely changed your description. You need to make sure that this is late arterial phase, because that's the hemodynamic, that's the hemodynamic of the HSCC and how it hyper enhances in the late arterial phase, where the portal vein here demonstrates some enhancement. So make sure it's late arterial phase that you're dealing with. And this is actually, again, clearly defined and described in detail in the manual. This is late arterial phase. It's a subtype of arterial phase in which the portal vein is enhanced. Okay, but the early one, the portal venous phase, is not yet enhanced. What about this? Would you raise your hand if you think that this is hyper enhancing observation? Again, this is late arterial phase, so it's good for you to categorize. This was categorized as hyper enhancing observation, but actually it was already hyperdense in the pre-contrast. So you need to be very careful. Not everything that you see it as hyperdense in the arterial phase is hyper enhancing. You need to review the pre-contrast to make sure it's not that this observation is hyperdense, not hyper enhancing. And what this happen, I mean, what scenario that make this happen? When it includes iron, cirrhosis, that cirrhotic nodule can be hyperdense, like what we see here. It's not really hyper enhancing, it was already hyperdense. You can just put ROI and know that the attenuation here is not much different. So not every hyperdense observation is hyper enhancing. This was regenerative cirrhotic nodule containing iron, making the nodule hyperdense, like what we see here. Okay, so what about this, guys? What do you do with MRI like that? Again, you review the pre-contrast. We review the pre-contrast for you. It's hyper intense. And you have a very important tool in MRI, which is subtraction, right? You have the subtraction, you did the subtraction. It's not really hyper enhancing. It was like just hyper intense. And it shows like this also in the arterial phase. And this led to its appearance, which is non-hyper enhancing here. This is non-hyper enhancing. It doesn't hyper enhance here. It was just hyper intense. This is dysplastic nodule, right? But what about here? Again, we see something that looks like hyper intense, right? And you reviewed the pre-contrast. It was already hyper intense. What do you do next? You do subtraction, and then subtraction here is showing you that this is really hyper enhancing. So you're comfortable calling this hyper enhancing observation. This is, you know, if you add up the major features, it's going to be likely HCC. So, or LIRADS 5, right? So you make sure, so these are the tips with and the pitfalls for arterial phase hyperenhancement. Number one, you make sure you're dealing with late arterial phase. You make sure that it's truly enhancing, not that it's hyper dense or hyper intense in the pre-contrast. And you make sure, as I said, in the pre-contrast CT or MRI, you make sure it's not hyper intense or hyper dense. Also, not every hyper enhancing observation is HSCC. Even the presence of cirrhosis, this is a case which shows you arterioportal shunting secondary to the tumor. Yes, there is a tumor here. There is an HCC here, but adjacent to HCC, there is aliasing on ultrasound, and there is serpiginous vessels adjacent to it. There is also early filling of portal vein, indicating what? Indicating the arteriovenous communication, and this is HCC associated with arterioportal fistula, which is common in cases of tumors. And this is the risk for something like that is what? Is number one, you don't want to consider this as a discrete observation, as a different observation. The other thing is you don't want to overestimate the size of the observation by including this shunting together with the tumor, right? So this is arterioportal communication, and it's very important for you to indicate. So again, those are the PAARS and pitfall with arterial phase hyperenhancement. We're moving to washout, and we describe it as non-peripheral washout. Why non-peripheral washout, guys? Because this is a case of peripheral washout. If you see a case like this, which is a rim, a hypointense rim relative to the center of the lesion, like what we see here in this case, and what has been described here in this case here, it's described in the delayed phase in the 10 minutes. It's described actually by Dr. Ahmed Ahmad Mahfouz in 1993 in radiology, but still it's a pertinent sign which is called peripheral washout. So if it's peripheral washout, it will be indicative of LRM, guys. Malignancy, not specific for HSC. It's different, it's probably different for HSC. In this case, it was cholangiocarcinoma, and we need to know why we saying that the major feature is non-peripheral washout, because the peripheral washout indicates something else, like cholangiocarcinoma, like metastatic deposits, like what we see here in this case in cholangiocarcinoma on top of cirrhotic liver. What about this? We see here, this is right hepatectomy. The patient has right hepatectomy for previous hepatocellular carcinoma, and we see here what? We see hyper-enhancing observation, and we see what's called washout, right? And it's 11 millimeter. You apply this table, and it will be LR5. Are we correct? No, we're not correct. But because the contrast medium we're dealing with here, I mean, I know that in Egypt or Europe, you call Primovest. Here it's called Eovest. It's gadoxetate disodium. When we use the gadoxetate disodium, you don't use the transitional phase. You don't use the hepatobiliary phase because it's hypointensity. It's not washout. You only use the portovenous phase when you're dealing with Eovest. Okay, so this is transitional phase. This is later than the portovenous phase. You can't use this. This actually was hemangioma, and this is very well known as what's called the pseudo washout or transitional phase hypointensity. That is miscategorizing this observation here, because you can't use later than the portal vein. You can't use the delayed phase or transitional phase in cases of gadoxetate disodium, Eovest or Primovest, like what you have in Europe or Egypt. So this is very important also, and it's defined in the manual. Portal venous phase only can be used to define the washout if gadoxylate is given. But if you have extracellular contrast agent, then you can use the delayed phase or portovenous phase. Very important, guys, to remember this, because then you will not describe this as a washout. What about this? This is a mass where the arterial phase, you don't see anything. And the patient here has history of, as far as I remember, has history of hepatitis B, or the patient even is obviously cirrhotic here. But you see hypodensity in the portovenous or delayed phase here in this case. What do you say about that? Would you consider this as a washout? Yes. The key lesson here is arterial phase hyperenhancement. So you don't see arterial phase hyperenhancement here, right? Arterial phase hyperenhancement is not required for the definition of washout. Is not required for you to characterize washouts. Why? Because 4% of HEC are visible only in the delayed phase on the first examination. Because what? Because early HEC may lose the portal venous supply before developing sufficient arterial neovascularization. So you don't see arterial phase hyperenhancement, but you can see it in the portal venous phase and delayed phase because you lose the portal venous supply. That's the hypothesis of why you're seeing this, why you're seeing the washout without actual observation in the arterial phase. And the other thing here, which is very important, is you could look at this. Oh, sorry, guys. Sorry. You could look at this and describe this as, washout, right? But this is actually not washout. And I'll tell you the proof of it. This is illusion to your eyes because you're seeing this enhancing capsule. Then you think it's the center of the observation is washing out, right? And this is very important, right? Because enhancing capsule is a major feature, but it's not as strong as the washout. So the proof here that this is capsule illusion and you don't see washout here is this is from my friend here, Claude Serlin. What he did is he did use the Photoshop to get rid of this enhancing capsule to show you that this is actually iso-intense, not really hypo-intense. So this is not unequivocally hypo-intense. So it doesn't qualify for washout, right? So this is capsule illusion. This is a very important pitfall that you guys need to know about. And the last thing, but not least, is enhancing capsule. What is this enhancing capsule? You still see a peripheral, hyper enhancement here in the portovenous and the delayed phase, okay? But you see it early on also in the arterial phase. That's a difference between enhancing capsule and what's called corona enhancement. Corona enhancement is one of the ancillary features for malignancy, right? Not a major feature like the enhancing capsule. That's why it's very important to differentiate. If you actually look at both of them and look at, difference is that this is enhancing capsule. It's crisp. It's well circumscribed, right? It's continuing to increase even in the delayed phase here, keep increasing in intensity. And this is opposite to the corona enhancement, which fades in the portovenous, and see how it was intense early on and then it fades on the delayed phase. And as I said, this enhancing capsule is sharp, smooth, uniform, and forms the edge of the observation. The corona enhancement is perfusional phenomenon, not a discrete structure. Maybe thick, it could be eccentric, it could be usually less well defined as we see here. So this is the last feature. Corona enhancement is not an enhancing capsule, and that's very important for you guys to know, and very important to tell the difference between them. And here is my take-home slide, which is very important. I went over all of these in my lecture: pitfalls, definitions of major features, and pitfalls. And hopefully, with using all of this, you will be able to reach diagnosis, and you will be able to avoid the pitfalls and characterize and enhancing observation in cirrhotic liver. With that, I thank you very much again, everyone, and it was a pleasure to be with you. And you know, I really have to go. So if there is any question, I appreciate giving it to me as early as you can. Thank you.
Thank you, Dr. Khaled, for the great presentation. I would like to welcome Dr. May Fawzi, Professor of Gastroenterology, Cairo University. Welcome, Dr. May. My pleasure to introduce the next speaker, Mayuri Joshi.